All right, let's talk about aplastic anemia. Now, I want you to picture a factory, one that's supposed to be cranking out essential products, running 24/7. But then suddenly, it just goes quiet. The production lines stop, and the warehouse is empty. That right there, in a nutshell, is aplastic anemia. It's a condition where the body's blood cell factory, the bone marrow, pretty much just shuts down.
So let's get right to the heart of it. At its core, aplastic anemia is a problem right at the source. It all starts with the hematopoietic stem cells, the master cells that are supposed to create all of our other blood cells. For some reason, these crucial stem cells get injured or suppressed, and when they stop working, the entire production line grinds to a halt. Okay, for anyone studying for an exam, this slide is pure gold. These are the three essentials for diagnosis, your classic triad. First, you get pancytopenia. That means all three cell lines are low. Second, and this is key, the few cells you do find look totally normal. There are no weird abnormal cells floating around. And third, if you look at the factory itself with a bone marrow biopsy, it's hypocellular. It's empty. Put those three together, and you're staring right at aplastic anemia. So here's our roadmap. We're going to figure out why the bone marrow goes on strike, what triggers this, and what clues you'll see in a patient's signs and lab work. Then we'll talk about locking in the diagnosis, walk through the treatment options, and wrap up with the prognosis and the absolute must-know takeaways. All right, first stop, what is actually happening on a biological level when this factory shuts down? Let's dive into the pathophysiology. So the term you need to know is hypoplastic. It means the marrow has very few cells left. It's been wiped out. And because of that, it just stops making mature red blood cells, white blood cells, and platelets. This failure in production leads directly to that huge buzzword we just mentioned, pancytopenia, a shortage of everything in the blood. Okay, so if the factory is shutting down, what's pulling the plug? What are the triggers that can cause this kind of catastrophic bone marrow failure? As you can see, there's a whole range of potential culprits. Now, sometimes it's congenital, like Fanconi anemia, but for your exams, you really want to focus on the acquired causes. Pay close attention to some of those classic medications like chloramphenicol, toxins like benzene, and of course, viruses. Parvovirus P19 is a big one, along with EBV. These are all well-known triggers. But here's the most important point. While there are a lot of different triggers, the most common reason, what we often call idiopathic aplastic anemia, seems to be an autoimmune attack. Basically, the body's own T cells get confused. They see the hematopoietic stem cells as an enemy and just start destroying them. It's a case of friendly fire. The body is literally attacking itself. So now that we know what's happening behind the scenes, how does this empty factory actually show up in a patient? What are the clinical clues and the lab results you're going to see? It really just comes down to what each cell is supposed to do. You don't have enough red blood cells? That's anemia, and your patient is going to feel weak and exhausted. Not enough neutrophils? That's neutropenia, which opens the door to all kinds of bacterial and fungal infections. And if you're low on platelets, that's thrombocytopenia, which leads to easy bruising, bleeding, and those classic little pinpoint rashes we call petechiae and purpura. And the lab work tells the exact same story. So burn these buzzwords into your brain. Pancytopenia is the hallmark finding. Critically, the reticulocyte count, those are the baby red blood cells, is always low. That tells you the factory isn't even trying to compensate. And when you look at the blood smear, the few cells you see look normal. The bone marrow biopsy is the final nail in the coffin. It's hypocellular. It's empty. That's the whole picture. Now, being able to tell aplastic anemia apart from other things that cause pancytopenia is a classic test question. You have to be able to spot the mimics. And the big one you need to distinguish it from is hypocellular myelodysplastic syndrome, or MDS. So how do you tell them apart? It's all about how the cells look. In aplastic anemia, the cells are few, but they look normal. In MDS, the cells look weird. They're dysplastic. In aplastic anemia, you don't see an increase in blasts. Those are the immature cells, but in MDS, you might. This distinction is absolutely critical to make. And remember this, what's not there is just as important as what is there. In a classic case of aplastic anemia, you should not find an enlarged liver or spleen, you shouldn't feel swollen lymph nodes, and the patient shouldn't have bone tenderness. If you find any of those things, bells should be going off in your head to think about other diagnoses, like leukemia or lymphoma. Okay, so you've nailed the diagnosis. Now what? Well, the treatment for severe aplastic anemia presents a major fork in the road. And the direction you take is based almost entirely on one thing: the patient's age. So here's your first clinical scenario. You've got a young patient, let's say under 40, and they're lucky enough to have a matched donor. What do you do? The answer is crystal clear. The treatment of choice is an allogeneic bone marrow transplant. This is the only thing that offers a cure. You are literally replacing the entire broken down factory with a brand new, fully functioning one. But what if you're in the other scenario? Maybe the patient is older, over 40, or they just don't have a matched donor available. A transplant isn't on the table. So what's the game plan now? For this group, the strategy totally shifts. If you can't replace the factory, you have to stop the attack on it, and that means immunosuppression. The modern standard of care is this powerful 3-drug combination. You use equine ATG and cyclosporin to shut down that T-cell attack, and then you add L-trombopeg to give a direct kickstart to whatever is left of the bone marrow. All right, let's bring it all home. How do patients actually do with these treatments? Let's talk about the prognosis and recap the absolute most important things to remember. For young patients who are able to get a bone marrow transplant from a matched sibling, the outlook is excellent. We're talking survival rates over 80%. This really just drives home why it's the #1 choice for that group. And what about for those who can't get a transplant? The news there is also really good. This modern triple-drug immunosuppressive therapy has an incredible response rate, getting close to 90%. That's a huge leap forward in how we manage this disease. It's not a perfect cure, though. Patients treated with immunosuppression need to be followed closely for the long haul. Up to a third of them might relapse, and there's a small but real long-term risk that the damaged bone marrow could evolve into other serious problems like PNH or even leukemia. And that brings us to our final thought. The very fact that one of our best treatments is to turn down the immune system tells you almost everything you need to know. It's powerful evidence that in most cases, this disease is an inside job. It's friendly fire. It's just a profound reminder of the incredible power of our own immune system, a force strong enough to protect us, but also, when it gets turned around, strong enough to shut down one of our most vital factories.